Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Gianluca Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. All right, so tonight it's Ryan's topic. Oh my God.
I hope you're all ready. We're going to talk. So I was inspired by the most recent NAVIS Spring Symposium. Shout out to Bartel. Something came up and I was like, you know what? We should really talk a little bit more about this from a anesthesiologist perspective. Let's talk about ventilation and how you approach it, favorite ways to do it, when are you doing it, why are you doing it, all the information you can get from it. Are you a permissive hypercapnia person? Let's get into that, what that really means, if it's worth it, if it's not worth it. So yeah, that's what I want to talk about today. So I guess let's start out with like how often are you ventilating? Like how often are you cranking on the ventilator?
If they ventilate normal, fine, and they're entitled to do it's below 60, I let them breathe on their own. But the other side of things is that if it's a longer procedure, probably I tend to put them on a vent more. Atelectasis is real, right? And so I don't know, sometimes I'd rather be a little bit more aggressive with it and just throw them on a ventilator right away. Of course, there are some cases where ventilation it's a must, right? Like your thoracotomies, your brain patients, of course, like those. We're not even talking about those, I guess, right? Like we're talking about otherwise.
We'll talk about those, but
Okay. Okay.
I want to know your average case who's getting anesthesia who doesn't specifically require ventilation for some specific disease process or some surgical portion of the procedure. Like, yeah, like, are you cracking it on? Like, I'll tell you, I, as a resident, it was like, once they were anesthetized, the minute they started to go apneic following induction, honestly, I usually just cracked the switch on the ventilator because it was right there. And
wait a second, I supervised you for a year when you were a resident, and I don't remember that because I would
half a year
stick if I had discovered that.
Half a year.
Half a year, yes. I had to leave because I couldn't take the insane amount of ventilating all the time.
Yes, yeah. Exactly. I feel like I ventilated them a lot more often. I think partly because it was accessible, partly because of the equipment we had access to. And now I'm going to say I'm more in the Bartel camp of I rarely ever break out the ventilator if I don't have to. Like I can get away with a lot of not starting positive pressure ventilation, and yeah, anyway.
But we are in two different settings, right?
Oh yes, yeah, for sure. And like for me, the ventilator is I have to get the ventilator, I have to connect it because the equipment I have, it's not built into my machine. I would love if it was. I just don't happen to have that type of machine. When it was there and readily available, it was like the decision to do it was much lower. Now I want to know what Bartel, where are you at? What's your approach?
I can barely hold it together right now, gentlemen.
I can tell.
Like this is a major source of aggravation for me in anesthesia in general. Yeah.
Yeah, I didn't know this would cause. I feel like I have a lot of like really big feelings about
this is like Bartel's sub-Q ketamine in Bailey's world. Like this is something that I will die on this hill. This is a hill that I would die on is ventilation.
Oh my God.
Yeah, I have some strong opinions for a change about this. So now that you guys have said what I think you have to, but here are my thoughts. Here are my thoughts, which are right.
Okay.
Ventilation, positive pressure ventilation, is an aberrant physiological state for the patient. And as a consequence, when we make this exogenous intervention and change the natural physiology of the patient, there are going to be consequences. I think that flipping the patient on ventilation automatically is either lazy or you don't understand the principles of most of your induction drugs, or the fact that your PaCO2 threshold for spontaneous ventilation automatically changes on the inhalation agents, and therefore you have to let it accumulate a little bit to drive spontaneous ventilation. And people are so busy freaking out about how often the patient breathes, even though it's cardiovascularly stable and oxygen saturating appropriately. So it's either lazy or you're too anxious to be able to control your own emotions. In either case, hate. And I think the one thing that we forget, we focus a lot about on ventilation in terms of, we always talk about like impeded venous return, so changing preload. That is actually only part of the concern. One of the things I think people really downplay, and particularly in patients who are sick, and particularly in patients who are going to be hospitalized long term, is we forget that it promotes an inflammatory process from the shear forces on the alveoli popping open and close themselves. And also the fact that you have to exceed driving pressure like to an extraordinary level to actually reopen alveoli, because they're either closed or they're open. They ain't halfway. And I do think that atelectasis is real, but I also, you can't tell me that ventilation, what's the difference between ventilating a patient in atelectasis and not ventilating a patient in atelectasis? Unless you are actually doing the specific maneuvers or interventions that are going to help you recruit and maintain open airways. So if you're not recruiting, if you're not using a bronchodilator, if you're not actually using PEEP, you cannot tell me that ventilation is going to, be your mainstay fight against atelectasis in your average patient. But I mean, the shear forces on the alveoli, the inflammatory process, and the other thing we forget is it changes intracranial pressures, and not just by driving CO2, but by actually changing central venous pressure. So there's a number of pretty significant consequences. And my whole point is that the body of the patient is smarter than the three of us put together. And in most instances, a healthy patient will compensate appropriately for being unconscious and still, and then make itself physiological stable. And I think we often ventilate them for no good particular reason and actually cause more problems than we're curing.
I don't know. I mean,
Yeah.
so,
We already skipped over your opinion.
whatever. So, I mean, part of this is, the setting where you're working is different than the setting where I'm working, right? Like, so I have cases that normally go way longer than yours, right? So, like, even a
Okay, so sorry, I
stay.
just wanted to clarify. So the setting comparison is academic versus private, right?
Right.
I didn't know if you were trying to like make this something about Oklahoma, and I was losing the track there. I was like, I
No,
don't know what
no,
happens in
there's nothing
Oklahoma
about. No,
versus
the
Canada.
weather has nothing to do with it, but
Corn.
definitely in an academic setting, you have students that are helping with the procedures or performing the procedures. Of course, like, that takes way longer than what it does in a private practice, right? So, like, as pay becomes a 3-hour procedure, it's normal, right? And so we administer 100% oxygen to our patients. We scavenge out the nitrogen skeleton that those alveoli have. Once you put them on their back, if they're hypoventilating, which they do with most of the induction drugs we use, atelectasis does happen, right? And so even normal ventilator settings with has a little bit of PEEP intrinsic in it, right?
Yeah, but that's only to balance the negative amount of suction being generated by the scavenge. So the net total is going to be insignificant physiologically to the patient.
Well, you still have like 2 to 4, right, centimeters of water. You do,
Yeah,
period.
whoop-de-doo, and that's what's balancing the scavenge, which is usually -2 to -6, and more importantly, 2 to 4 pretty much in the literature has not really shown to do
Okay,
Bibby
fair,
Bupkis about atelectus.
fair. But then if you actually measure an ETCO2 PaCO2 gap, you would see that you have a much better values with starting ventilation immediately rather than starting it 2 hours later when your end-tidal CO2 it's now above threshold and you need to start ventilating it, right? So being
I would give you that in a horse. I'm not sure I'm willing to concede
it's
that in a cat or a dog.
100% the same in a small animal, and the
No,
same as it is in
no,
a human.
no. If you don't
100%.
ventilate a horse from the get-go, you are going to get hypoxemia, a relative
No,
hypoxemia.
no, of course, but
That's involved.
the gap is, that occurs with
But
small
the
animals.
average gap is 5 to 8 in a dog. So why are we getting upregulated about ventilating? And if we know that's going to happen because of recumbency and sedation anyway, like that whole my point is that things are going to change, sure, but what degree of change is clinically relevant?
Sure.
One of the other issues I take with ventilation too is if you do it wrong, either hypoventilate them or hyperventilate them, that can also be catastrophic in and of itself. So, I mean, the number of times I've seen massive kerfuffles with the ventilator, either not driving appropriately or, driving too aggressively, that gives me pause to think that it is not benign. And I think that we are often too quick to jump to it without legitimately good clinical reason. Interestingly, also, just parlaying a little bit into a slightly related topic, which Bailey touched on in his intro, is that I just came from the AVA conference in Vienna last month, and they had a human speaker come in, and then there were a couple resident abstracts, and they were actually looking at the ventilation modes and whether or not that improved ventilation and whether or not that improved oxygenation. So, do you drive pressure? Do you drive volume? How do you cycle it, etc.? The findings are pretty inconsequential, like whether you drive pressure, whether you drive volume. And I thought that was really interesting. Yeah, I thought that was
I
really
mean, it
interesting.
makes sense though, right?
And my best friend in real life is actually a human cardiothoracic transplant respiratory therapist. And he basically has told me before, he's like, oh, potato, potato. Like people spend way too much time like making like these academic, assertions about the mode. And he goes, at the end of the day, like he's like, I drive on volume. And he was like, these are like, post-COVID patients, these are post-transplant patients, and he's like, I let the blood gas dictate it. So he was like, what do you care if you drive volume or what do you care if you drive pressure, right?
Yeah. No, I mean, I always drive volume too, right? I set a pressure limit, right?
Mhm.
Then I usually use volume, right? It's especially like if you have people that are manipulating the abdomen or whatnot, and they can put pressure on the diaphragm.
Yeah, or they relieve the pressure on the diaphragm, and then you're on, you have to actually be very careful if you have changes in that extra pleural pressures or those extra thoracic pressures, because if they take pressure on and off the diaphragm, if they open the chest, if they close the chest, what you're driving is going to change significantly based on, if you set volume too low, then you're going to achieve a really low pressure after they take diaphragmatic pressure off. So that's what I think. I think ventilation gives people a false sense of security, and I always object to anything that we do where we remove our ability to critically think about what's happening with the patient and how what's going on in the procedure is also affecting the patient. In this case, opening abdomen, opening chest, closing, positioning, what have you, obesity, what have you. I think your point about duration, right? Because usually duration incurs more hypothermia incurs more hypotension, positive pressure ventilation, what is their depth? But, I see a lot of people just flick the ventilator on and basically tune the fuck out about it. And you're just like, the
Yeah.
critical thinking evaporates, which causes me concern.
You may also be overthinking it a little bit, right? But it's okay.
Gianluca, I mean, I'm not though. And that's because, you know why? Because I only see ASA 4s and 5Es, right? I don't do spays and neuters. Like if they call me down from like the lofty offices of upper management, it's dying on the table, right? It's dying on the table.
Do you even remember how a ventilator look like nowadays?
Well, not a
Just
bag and a
wait, just wait.
barrel.
Martel's gonna be like, yeah, it's right here.
The other thing too that I also think that we take away too is one of the things I've seen a lot of people make like overt mistakes on is patients who have like a chronic acidemia, and then people want to bring the PaCO2 between 30 and 45, and that
Yeah.
patient has actually, shifted their pH curve because they've been chronically acidemic. And then we get in there and we're like fucking gung ho about ventilating it to 35. And I'm like, you're going to kill it. And I was just like, you're going to drive the pH absolutely into the toilet if you don't actually let that patient maintain its baseline PaCO2, because now it's in a state of chronic compensation. Like I said, I just feel that we flip to ventilation literally and metaphorically in a manner that for me is either like it's very irreverent, and oftentimes I find it lazy. I get why students do it, but even in that case, like it's fine, it's probably more fine for ASA ones and ASA twos, but in ASA 4 and 5 world, I want that person paying attention and thinking. So yeah,
Yeah,
told
no,
you
that's fair.
very strongly about ventilating.
Well, that was unexpected.
Yes.
Bit of a shock. Thought we
Yeah.
might be able to fill the hour, but I think we're going to be just fine. I didn't know you all had such strong feelings. I love it. It makes me feel good because I have a lot of strong feelings. So, lot to unpack. But let's say we've got the average. This is a healthy patient, does not require ventilation for a specific reason, but we have chosen to put it on the ventilator. So, one, I want you to talk about like which modes are you using? So volume or pressure? Are you going to use a PSV or just like a full control? And then what's your CO2 targets? Where are you trying to drive CO2 to in your average patient? I'm going to get to sick patients. We can talk all about like all those little idiosyncrasies, but like, what are you doing for your regular one? What's your rate even? What's your inspiratory time? Like, are those all things you're thinking about?
I don't even remember the first question now, but that was a lot.
I mean, what are the settings you go to when you start this patient on the vent, and your end goals kind of when you start? Because like you're gonna take this patient. I don't know. Let's say it's an average healthy TPLO, CO2 75, 80. Okay, that patient almost requires ventilation.
Sure.
Heavy-handed pre-med.
Speaking of dogs and cats, right? Like for now, we can always move to
Um,
reptiles or horses or whatever.
yeah, I think probably we'll start with dogs and cats. I mean, I guess the inspiratory time question really is a horse question, but I think we can. Yeah, we'll start with dogs and cats, and we can go into horses too.
Because I was like, let me be clear. I mean, reptiles. Oh.
I'm gonna skip over exotics because it's way too complicated.
Reptiles. Remember, Bailey, we were going to write that chapter on reptile anesthesia called "We Don't Know If It's Dead." Half the time, you're like, I don't know, dead, live, I don't know. Look smart.
Heart beating could mean anything.
I guess okay. So when I go to set settings, I think the one thing too that I find is under taught for when people learn how to ventilate, and I try to keep things simple. Like I like to always use like base 10 as a number in a lot of my teachings because people can remember it and they don't get panicked about it. But one of the things I also teach is that you have to remember to lean weight for lung capacity, right? Mm-hmm. So if you're going to drive a tidal volume, you're actually, you have to take into two factors. So for example, if this patient is, being positioned in a way where I feel like, its thoracic excursion might be impeded, I'm inherently going to drive, a higher pressure, for example. But if I have a patient who is, quite obese, I'm calculating my tidal volume off of what I anticipate to be their lean weight, but also remembering that the obesity contributes to increased extrathoracic pressure. And so I'm going to keep my eye very closely on what that driving pressure is and what then my PA or my end tidal CO2 are and titrate from there. Because what I don't want to do is, drive a volume that is going to cause overexpansion of the alveoli, which is what, like I said, particularly in a patient who might already be in a state of SIRS or pro-inflammatory and actually worsen that inflammatory process throughout the body. So I tend to start a little bit more conservatively and then dial up from there. Now, my personal record for a PA CO2 in a patient, 147. 147. It obviously, in that case, I started ventilation a little bit more aggressively. But like your average healthy pet, I'm going to want. What happened is that when we didn't have an endobronchial blocker, and when the surgeon went to take out the like infected tumor lobe and clamped it off, it burst, and then everything dropped dependently into the good lung. And so I just had fulminant barrier. Like the patient basically aspirated on its own bodily fluids.
That's beautiful.
And I kept it alive for like maybe 45 more minutes, but it was like basically in a constant state of CPR. Right.
What was
Holy
the was that was arterial CO2?
Unfortunately.
What was that entitled at that time?
A billion.
wow.
I just I wonder if there was a huge gap. Like,
There was a huge gap, right? Because I was just blood trapping the CO2. And, so like the end title was probably like low 40s, which is higher than what you expect. But if you actually look at that driving gradient through, like whatever was passing through is inherently going to be high. But the PaCO2, like I definitely lost sphincter control around that point. But anyway, so like my average settings though, like I'm probably going to drive around 10 centimeters of water, average dog, 10 to 12 breaths a minute. And then I just titrate to the individual from there. Right. But that means I have to constantly check back in, like, every few minutes while you let those ventilator parameters settle in and that patient accommodate those changes. And then you come and you titrate around. But those are sort of my baselines for things that are very straightforward.
how about generic goal CO2? When are you going to start to get itchy to back up, and when are you going to start to get itchy to get
So
more aggressive? In
my head,
average healthy patient CO2
right.
80.
So in my head, I assume that my average healthy TPLO dog is going to incur a gradient somewhere between 5 to 8, right, millimeters of mercury. So in my head, if my end tidal is 45, then I'm basically imagining that my PaCO2 is 50 to 53, right? That's the average. So I was like, a bare minimum, that's probably where I'm sitting. I don't get terribly twitchy until I start to, think that probably my PaCO2 is climbing into the mid 60s. I don't mind a little bit of permissive hypercapnia, and not just permissive hypercapnia. So a little bit of built CO2 buildup for our listeners. So it actually helps you with cardiovascular tone, because I always teach this. I always say, if you hold your breath for a minute, what happens to your heart rate, right? It goes up because your body's like, whoa, we should get rid of the CO2. So you get a little bit of cardiovascular tone in a healthy patient. And the other thing you also get to is, remember that, like I said earlier, the inhalants sort of dysregulate your normal respiratory drive mechanisms, which is usually high CO2, unless you're really dying, and then it's low oxygen, unless you're a reptile. But anyway, so, I do know in my head that I got to get up to above 50 or 55 if I want them to breathe on their own, which, as per my rant earlier, that's what I'm cutting for. So, my CO2, if it's sitting at 30 from ventilation, I don't fuss too much because I know it's still in the mid 30s. If if I'm weaning them off the ventilator, I'm going to let it build up into the 50s. But I really don't want to intervene until you're sort of in the 60s areas, because that little bit of CO2 buildup is beneficial, but I'm not going to start to see that incremental increase in the adverse effects. So changes in pH, myocardial depression, changes in intracranial pressure, narcosis, right? So yeah, and I know people get really like worked up about 80 and 90, but you can coast through that level for a surprising amount of time before the patient is really gonna like go off the rails. But anyway, yeah. So I do the math a little bit in my head, and then it also depends on what my goal is. Am I trying to get them down, or am I trying to wake them up? But yeah, that's my 2 cents.
I don't know. I think going back to your initial settings before, I think usually, so the nice thing of these new machines we have is that you literally set the weight and it does all the math for you. So the
Yeah.
presets are, you can change them, but it's the level of laziness that you can have with these machines is like through the roof. But anyway, so I usually start at like, on lean body weight, about like 10 ml per kg, usually, of tidal volume. I try to start low, and then I start with volume control, pressure limited. So, like, usually I limit it at like 20 centimeters of water. The respiratory rate, I don't really have a starting setting. Depending on the breed, I go between 8 to 10 in a large breed, and to 12 to 14 in a small breed. And then I go from there. I use you to kind of guide me a little bit. The other thing I look at is like compliance, right? Like, so I want to make sure that, I'm not, for that kind of volume that I'm putting in, I'm not hitting too high of a pressure. but yeah, that's mostly what I really look at. I try to target an entire CO2 between 55 and 60 ideally. If I have a block gas, I measure the gap and I go from there really. And that's again for small animal. Horses, it's a slightly different kind of beast. There is a couple of different train of thoughts on horses, right? There is some people that prefer to start ventilating immediately, do mundane oxygenation, and then there is something more like focused on the cardiovascular side of things and not starting ventilation right away. I don't know. I think I don't want to criticize anything. I care more about oxygenation and put them on the butamine if the cardiovascular sucks. But it's kind of hard to catch up on ventilation. I think once the atelectasis developed really badly in a horse, I think I
Oh
rather not.
yeah, it's a nightmare. If your horse is like, if every
Yeah,
serial ventilation reading you take, your PaO2 is going down and down, like it's time to start telling the surgeon to move.
yeah,
I
yeah,
mean,
So guys, in terms of ventilation, here's something that I've never been able to rectify between what is actually published robustly in both human and veterinary literature and what I actually see clinically, which I understand is anecdotal. But there's a lot of papers out there about the high frequency ventilation with the low volume, right? Like, so you want to ventilate to like 6 to 8
yeah,
centimeters of water, and you just want to have a higher ventilation rate. I have never clinically done this with a significant degree of success. I sit here and I actually, this is how I learn respiratory physiology and ventilation. So I actually sit around doing all these weird breathing patterns because I'm like, well, what happens if we breathe like this? Right? It's basically dead space ventilating. It doesn't go into like the deep, like third component of like, obviously I'm bipedal most of the time, unless it's Saturday night, but, um, like I'm not ventilating into my deep lung tissue, which means for sure I'm shunting like a mofo, right? And so, and every time I've gone in and like the criticalist and I are chit chatting, and I'm like, "How's this patient doing?" And blah blah blah, blah. And like this could be like when I worked in Singapore, for example, we ventilated a lot of cobra bite patients, and they'd be on the ventilator for 3, sometimes 4 days. I know it's weird, right? But the criticalists are very motivated to drive this sort of low pressure, high frequency ventilation, and then we would pull the blood gas, and without fail, we would have wildly high PaCO2s. And I was like,
it's
you
huge rating.
to drive either a higher pressure or volume. In other words, you have to increase minute volume. You have to do it. And like I said, the problem I have with like really rapid positive pressure ventilation is biotrauma, right? Or the shear stress on the alveoli that's going to precipitate an inflammatory reaction. Oftentimes you'll see those patients will start to have signs of like, looks like they're slowly aspirating, and what they're really doing is they're going into like ARDS. And I have never been able to successfully manage this low pressure, high frequency ventilation so that my patients don't end up being wildly hypoventilated unless you drive the frequency so high that you're basically created a jet ventilator with your normal ventilator. But like, do you guys do this 6 to 8 shenanigan? And if so, what am I doing wrong? Like, how is that working? Why am I not aligning with all the literature?
So I think there's a couple things. So I tried this after reading that like lung protect or high low whatever
Right.
human paper was hot at the time.
And
And
surviving sepsis tells you to do it
yep.
too. And I'm like, oh,
And I remember my waveform. I've got a little diagram here, like this.
for
And
the
I
people who
remember,
aren't watching this, Ryan just drew basically like a line of sawtooth
yep.
triangles.
And I was like, we're doing high low, like high frequency, low volume. We're gonna like do, and we had the fancy ventilator in my residency, and this was like a PDA dog, so it was like relatively compliant on a lot of injectable anesthesia. So like the ventilation was already kind of disturbed by the drugs we were giving. So I was like trying this new strategy for like more cardiovascular stability. And my faculty was like, go pull a blood gas right now. And I pulled it, and I swear to God, PO2, PaCO2 was like 90.
Yeah.
And they're like, yeah, there's a huge gradient, and like you can see with the sawtooth pattern, you're not adequately sampling the alveoli, and so the machine is lying to you. So like, don't monitor the monitor. So that's like stuck with me forever. I don't know. Like, I've always wondered if it's just a difference in human physiology versus like dog physiology, because that's realistically this high-low strategy is what we're trying on dogs and cats. We're not trying this on equine species because there's the
Well, the
kind of
ventilator would explode. Like there's
yeah,
like
yeah. But like
they're not sophisticated enough to drive like that. That's why.
I've never been able to succeed with this strategy in a dog or a cat. And I find more often than not, you end up doing more, I guess, dead space ventilation, or you're not adequately filling the alveoli. So you're not getting good gas exchange. So your CO2 numbers are like wildly inaccurate. And so when I have actually this brings up a point that is like a big pet peeve of mine. When I walk in the room and the respiratory rate's goddamn like 25, I immediately like freak out and I'm like, crank down the rate. You're way too fast. You're undersampling. It's going to be inaccurate. And then sure enough, I like whip the rate way down. I crank the volume up, instead of these
And your
little,
first, I bet you your first ETCO2 reading is like 79.
yeah,
And
it spikes up
you're
like
just
20
like,
points. And I'm like, yeah, I wonder why the dog was bucking you on the ventilator, because the CO2 is completely inaccurate and you're chasing your tail because you're not like understanding what the screen is telling you. So to Bartel's earlier point about why I don't ventilate anything.
no, but I mean, like I said, one of the ways I genuinely understand like respiratory physiology and ventilation per se is I mimic the breathing pattern. And then I actually pay attention to like, do I feel short of breath? Do I feel lightheaded? What's happening to my heart rate? Right. And obviously, like in most cases, my blood pressure is high anyway, because I just ate deep fried pickles. I'm an anesthesiologist. So, but yeah, like I was just like, if you breathe like that, like, you know, you are not going to the gas exchange surface of the pulmonary tree. You are sitting in anatomical dead space area. And eventually, like, you're just like, your body is like, I don't know what you're doing, but this is really stupid. And you need to sigh, essentially. Like, it'll be like, again. And yeah, I just, like I said, and I've met a couple of people who ventilate, and this is like long term ventilation in patients. Obviously, if you're on long term ventilation, by definition, you are not doing well. And like they're not actually checking the blood gas because like they're like, that won't make me feel better. And I'm like, I'm not sure.
Yeah.
But anyway, yeah, and then the other thing too is like your PCO2 is up there so high, like your pH is going to be super acidemic, and then you got to start norepinephrine and blah, blah, and I'm just like, you're fucking everything up because this ventilation modality, for me anyway, just doesn't fucking work.
No, no. I mean, we did have a jet vent at NC State, but that's a totally different story.
Yeah. Oh yeah.
Right? That's a totally different.
I actually find jet ventilation very stressful.
Oh my god, I love it. It's so easy.
I don't know what it is. I just get so stressed about it. I'm just like,
Yeah,
oh,
I mean, it's cool, but like yeah, everything above, I feel like everything above 16 or 18 on a normal ventilator doesn't get you a very efficient
Yeah. Yeah.
ventilation. And I do, to back to your point, Dasha, I actually do really care about eye ratio in small animal and large animal. I don't, I, the ideal, it's, people say between 1.1 to 2 or 1 to 3. Usually I set at 1 to 2.5.
yeah, me too.
And sometimes people look at me really weird because I'm getting to this like very precise spot, 1, 2.5, right? Like rather than 1.1 to 2 or 1 to.
I would say 1 to 2.5 is my default IDE. And the other thing too is that I do a lot of farting around with the IDE and not changing the other settings per se.
Yeah.
I find that conceptually, it's one of the concepts that people really struggle to understand is the IDE ratio. And I end up drawing like lots of lines out and trying to like teach that. But like, if you're on one of those ventilators where you actually set volume by the IDE, for example, like the Equine Mallard, you do have to wrap your head around it. But I will use it to control like that breathing pattern because, ideally you want the ventilation to mimic the natural breathing pattern, which is in, pause, out, longer pause, right? Like nobody breathes like this.
I
They're
make people do that
faint if you breathe like that. So
when they have the vent at 30 breaths per minute. I'll be like, please breathe at 30 breaths per minute. That's 1 second in, 1 second out. Try it now. And they're like, yeah, you can only do this for like 30 seconds before you're going to faint.
You can't even make it to a minute because your body is like, voluntary control has been overridden due to overt stupidity.
It's so unpleasant.
Yeah, that's how Ryan breathes after the 5th hot dog.
Yeah.
Yeah, because his like transabdominal thoracic
sodium is just
pressure
like
is like
the roof. My body's like, what do I do?
That's the acidosis from those pickles.
Oh my God. You must have the worst reflux.
I think the hot dogs, it's some sort of combination, like just keeps me regular, you know?
So I went up to see Ryan, and the giardiniera. So in Italy, we do have this giardiniera, right? Which is basically like, pickled vegetables, and that's it. But the one that they have in Chicago, it's so fucking hot.
Oh, yeah.
Right?
Oh, okay.
It's so good.
I almost died the first time, and I went on it very easy because I was like, okay, I had this in Italy. I love it. We eat it every time. It's totally fine. I wasn't expecting how hot it was.
So basically, I'm the Chicago spicy version of the normal Italian thing when we talk about ventilation.
Yeah. Oh, yeah, for
I
sure.
got unexpectedly spicy about a topic you didn't even know. Yeah.
Actually, this company is a Chicago company, and they make a hot giardiniera that is my personal favorite. And one of the ways they like to eat some of their hot dog adjacent items, the Polish, which is like a Polish sausage on a bun, they put giardiniera on the Polish sausage. I've since tried it. It is really fucking good. So a recommendation for your summer grilling, get a Polish sausage, cover it in giardiniera. Dope.
I don't know why we haven't picked up a sausage sponsor by now. I mean,
I'm trying my goddamn hardest.
I know we are just promoting the absolute like crapola out of these sausagey products.
Very local.
We love Chicago hot dogs, and I just feel like we really need to start, getting that message out there to the guys that they really have an audience capture in the veterinary anesthesia community, which is an untapped market for them.
I will say, someone came back and they said our podcast on fluid therapy, they were at an anesthesia conference this last week, and they said our topic on fluid therapy was referenced in one of the presentations, and that fluids are a drug. And I was like, oh, my little heart is so happy.
Oh
I
my
was
God.
told at the Vienna conference that my tagline, which is "Let's all learn to walk before we learn how to fly," has just taken off in anesthesia schooling in Europe. Everyone in Switzerland apparently is saying it, and I was like, "Hooray!"
Wow.
Pretty sure I didn't make that up, but I'll take the credit. Although I don't want to be formally referenced because, like, disclaimer: if you follow our advice and something goes badly, I don't want any liability.
All right. I feel like I have a list of topics here, and we're definitely not going to get through them all. We're not even going to come close, and this is just a quick handwritten note. But I do want to talk about equine ventilation because it gets into one of my personal favorite ventilator things, inspiratory time, and how we can adjust inspiratory time, which also then gets at like inspiratory flow. Do we rapidly ramp up, or do we slow push up? Yeah, what's your approach to equine ventilation? I'll start first just because I haven't done much talking about what I do. I don't do a lot of equine anymore, but when I did, I think I tried once or twice to not ventilate to try. Let's see how they do. He's on his side. It's gonna be just fine.
No, it's not.
Spoiler alert! It was
1,000% not.
It was not just fine. The horse did, I think he desaturated. We had to get him on the vent. It was a whole big rigmarole. And, this was back in the day where we did not have the fancy ventilators. So we had the bag and the barrel situation. And
I
that
hope
thing
I
was like,
wasn't the chief supervising you on the case where you
no,
were
I'm
like,
sure,
"Here,
I'm sure
enjoy
you
this
weren't.
horse," because I definitely would have like wrapped your knuckles for that.
Oh yeah, I'm sure you weren't. But yeah, it did not. I mean, I think some of the faculty there were a little bit lenient on like the like laterally recumbent horse that they could be okay ventilating. But yeah, this horse was definitely not, and we had to like get the ventilator and do all the rigmarole, which is fine. But I ventilate pretty much everything. Um, Obviously slow rates, long inspiratory times, 2 to 4 seconds, depending. I think I started on the low end, like the 2 second inspiratory time. And then when I had trouble,
But you
started to.
need that inspiratory time to fill that volume of lung. Like,
Oh yeah, I totally agree. I just wasn't always on the like, if I, waveform analysis is obviously so much more important on the ventilators. If you're getting those nice plateaus, I was generally okay with it.
hmm.
Where if I wasn't getting the plateau phase, I was not trusting my CO2 and would definitely slow down my inspiratory time or increase my volume to try and get, that better waveform so I could trust the numbers.
I mean, I certainly don't crank my flow rate like a jackass from 0 to hero
No, I
either.
mean, like some ventilators, you can actually control the way I don't know how many of the anesthesia ventilators, but I know
There are small animal ones where you can do that too. But if you
yeah,
notice, if you really drive the
right,
flow
that's what I
rate,
meant.
like the liters per minute to the ventilator,
Oh no,
you
what?
actually drive the PIP
Yeah.
in the patient up, and you'll see it on the waveform because they'll be like it's almost like the opposite of a curare cleft. You see like an early
Oh,
phase like spike, and that usually tells me like, ooh, flow is too high. And
yeah.
again, I don't think that's good for like this delicate,
No.
sometimes variable, inflammatory prone lung tissue.
Yeah,
So
no, that's not. I wasn't saying to adjust my oxygen flow rate. More that like in those really nice ventilators where you can actually say like rapid inspiratory flow versus a slower. I don't know it well enough to know like how they set the parameters, but I know on the critical care ventilators you can actually change the way the breath is firing into the
no, that's
lungs.
what I'm talking about, Bailey. If you change it so that
Oh,
the rate of the flow, right? So you're actually driving like a high velocity inspiratory
yeah,
flow
yeah,
from the ventilator, not your oxygen flow meter.
yeah. Okay,
You
that's what you're
will
saying.
drive an increase in pressure, and you will see that spike on your tracing.
Oh yeah,
Yeah,
I
and
think
that's
that's
from
how.
the ventilator control, and like you can adjust your oxygen as much as you want. But yeah, no, that's from the ventilator flow. But like I said, like rapidly moving air, which is cold, is can cause, shear stress
Yep.
on the tissue. So I generally, unless I'm in a, grave pickle, tend to err on the side of being more judicious in that
Yep.
capacity.
Yeah. Yeah. I mean, I don't have oxygen driven ventilator for horses, so we have two Taphoniuses, and so
Okay.
like
You have
they're piston
non-pneumatic. Yeah.
yeah, they're piston driven. So but you have different ventilator modalities, right? Like there's this new like flex ventilation and whatnot that they developed at UPenn, I think. you know yeah, if I can, I try not to have that blast off,
Oh
you know
yeah.
super fast.
Just shoot the patient right off the end of the circuit, right? Like,
Right, right.
Just
I try not
rip
to do
their
that.
lungs into the chest.
Yeah, right.
One breath, and we're
of
off to the
course, but
races.
guaranteed you could like rocket fire a budgie across the room with that kind of behavior.
Oh yeah. Yeah, no, I try not to do that.
Otherwise.
But I mean, the other thing that people need to, and I think that a lot of people forget, is like, how all the physiology about like, the time constants of the different alveoli, right? And in different areas of, the lung and, how they, so, I mean, that's something that, people sometimes forget and like, they don't, and that goes back to your comment, Dasha, that, these machines can be dangerous, right? It's you need to know how to set it up, and some of them have more fail safe than others. Unfortunately, the ones that we have in vetmed, especially the holder stuff out there, it's kind of on the sketchy side. So
Just as cross reference, like the time I was on large animal at Davis, and Christine exploded the bag in the barrel, and it sounded like someone had fired a bazooka in the clinic. And I swear to God, my heart stopped beating for at least 4 seconds. Like I had
Nice.
zero perfusion.
I will say, I know there's a lot of hate on the bag and the barrel. That thing was a fucking workhorse. That thing, if this, you knew when the PaO2 got down below a certain level, the only reason was because the ventilator was fucking broken. I remember one time I think I had a PO2 in a horse of 60 or 80, and I immediately recognized it was because the ventilator wasn't working correctly. And I was like, thank God it's not this horse is dying in front of me. It's because the equipment is dying in front of me. And you know what? It happened another time, and I was right. It was also an equipment related issue, and it was not the horse dying. So, fix the equipment, fix the problem. It was instantaneous. Once you resolve that, it was off to the races.
Yeah, I mean, I could drive a car or I could have 50 people pull me in a cart to work, but guess which one I'm going to pick? like, great.
So, what are you doing with your equine patients? How are you're ventilating everyone at this point? Are you allowing them to do it on their own? Are you
Fuck no. No, I ventilate them all, start from the get-go, usually 6 to 8 breaths per minute, aeration of 1 to 2.5. Tidal volume depending on size, of course.
right?
Pressure limited, usually 40-ish, 45, as a starting point. And of course, depends on, if it's a colic where the abdomen is bloated,
Right.
we may need to go in a different direction there. But usually that's my starting point, and we ventilate from the second it's intubated, hoisted on the table, connected, press start, boom.
Yeah.
Beanie and I have now realigned. I think you will die more quickly of hypoxemia than you will of hypotension.
That's
So I
good.
also ventilate from the get-go because just like Beanie said, I have more rapid and more reliable interventions to address cardiovascular status than I do equine hypoxemia.
Oh yeah.
Yeah.
There's actually only a finite number of things you can do. And if they ain't working, it's going to die. So, I don't want to be behind the curve on oxygenating the equine patient. So I am going to ventilate from the get-go. I might not be crazily aggressive on that first 2 breaths, while you're trying to get the art line in and see what its pressures is and what have you. But at the end of the day, I've had colics at the tables, with systolics of 40. And you can get them back but trying to get a horse out of a PaO2 of 45, fuck, I wish you well.
Oh my God. Yeah.
By then the guts are blue and the surgeons are losing it, and it's it's never going to stand up.
Yep.
I'm more tolerant of the hypotension than I am of the hypoxemia. And like I said, I can fix it more reliably than I can if I get behind with atelectasis in a horse, because first of all, performing a recruitment maneuver in a horse,
Yeah, good luck.
good fucking luck.
Yep.
And, it's already on 100% oxygen. I can't give it more, so it's just your ability to address it is extremely limited and mostly inefficacious. So it becomes a time game to how long you can tolerate this relative hypoxemia before it's going to impede recovery, tissue healing, viability on the table. So yeah, I ventilate from the get-go. My parameters are very similar to what John Lucas said. Yeah.
I feel like the only thing you can in the hypoxemic horse, or the horse whose oxygen tension is, maybe they're not hypoxemic yet, but they're dropping like a stone. The only thing you can pray for is that your CO2 gradient is so high that you're like, oh crap, I can expand the lung a little bit more and get more alveoli to participate because I'm underventilating a little bit, and that's all you can hope for. And otherwise, just shit, batten down the hatches. It's about to get real, everyone.
It's usually when I sort of come a little closer to the end of the surgery table and I'll be like, things are not going as well as I would like. So anything we can do to expedite this portion of the procedure would be in the patient's best interest.
Are you I remember reading this as a resident, and I don't think it ever really became in vogue, but there was some literature about PEEP in horses from the jump.
Yes,
Like,
I remember that. That was a big deal when I was a resident.
and I think they were going up to 20 centimeters of water PEEP and that's where they really achieved a difference.
Well,
Which
basically, like you can
which
take your
is
5
wild.
cm PEEP, insertion and just fucking throw it in the
Yeah.
garbage,
Oh
right?
yeah.
Like especially for equine.
Yeah.
So yeah, no, the papers that came out where they looked at the recruitment mover and the recruitment maneuver timing and driving pressures, and then the amount of PEEP you had to set to maintain like open lung capacities,
Yeah.
where it would kill a cat, right? Like it would kill
Yeah.
a cat,
Oh yeah.
right? But
Oh
yeah,
yeah.
no, you have to drive like up like 20 of PEEP,
Yep.
26 meters of water PEEP, and your recruitment maneuver pressures, you're going up to 40, 50. They
Yep.
drove up to 70, I think.
I
Uh,
think so.
and I was like, somebody has very large gonads. But
Yeah.
yeah, they drove like in like parameters that when I think the paper first came out, everybody was like, this is insane. And like I said, would kill a person, kill a horse. Sorry, kill a person, kill a cat, kill a dog, kill a cat. But a horse is a horse of a different shade. So, but yeah, like it's like I said, this is my whole point about hypoxemia. Like it is incredibly difficult to address. You
Yeah.
have a very limited number of things you can do, and most of the time, unless you are going to do it with balls to the wall aggression,
Mm-hmm.
you are just going to watch PaO2 slowly go.
Yeah, you're fucked.
Yeah.
Yeah, you're fucked. At that
And
point, you're
most colics don't start like most colics are not going to the ground on the first 3 breaths with like a PaO2 of 600. So
Oh
if you
yeah.
go down to 400 over the next 45 minutes, who cares? Most of my colics hit the table. I'm like excited if it's 220,
Yeah.
oh
right?
yeah. Yeah. Yeah.
Because then I'm like, cool, I have about an hour before it's going to hit around the 100 mark and I'm going to start to get clenchy. But yeah, so I think, yeah, those are equines are, yes, they're significantly more challenging from a ventilation point of view, which means I tend to be more assertive in that capacity.
Let's talk about cats.
Okay.
Fucking Ryan.
I mean, I feel like they're also different. Like
Yes.
a they don't hypoventilate, so it's rare that we need to ventilate them. They fucking hate ventilation. Like they do not take to it well at all. Like unless you're paralyzing them, and then tough shit. They got to eat it. And like they are just immediate blood pressure in the toilet, like the lowest pressures you've ever seen. Like, and I don't. This is another thing I don't understand, and I'm going to ask you all because like I've had to deal with this, and I'm like, what the fuck's wrong with this fucking cat? Why are cats this way? Cat, open chest, they're breathing, spontaneous,
Mm.
and I'm like, how are you doing this? How are your lungs still open? Like, what is going on?
It's just the sheer nature that cats do not want to be told what to do, and their lungs are
Yeah.
just like, I'm the
They
last.
can't die. They can't.
They, but
Are
yet they
allergic to death.
like. What do you do? How do you approach cat ventilation? Cat with the you've got classic example for me from residency. You got the uremic acidotic cat. They're on the table. Their pH is like 7.0. Their potassium is creeping up, and you want to take that pH and start to drive it up, and you've got to get that CO2 down because it's like 60, 65.
I'm
Well, if that's a chronic metabolic acidemia, then you probably shouldn't be dicking around with ventilation. You should be
But
getting.
it's not because these cats are obstructed and they're like in AKI.
Oh, right. Sorry. I forgot it was an
Yeah.
obstruction. Yeah, my bad.
Yeah.
I mean, my bad. Sorry, it wasn't acute. Yeah, but I was like, don't fucking do that in a chronic CKD patient, Bill. You'd kill him.
Right. Sure.
I was like, were you not listening to me rant before? But anyway, no.
We just are like, oh, this is a chronic CKD cat. We won't be ventilating him. He'll be just fine, and somehow he will anyway.
I mean, the other thing that's weird about cats and like respiratory physiology is how markedly they are like intolerant to aspirating. Right?
Oh my god.
If a cat aspirates, you
oh,
toast.
you're fucked.
Yeah,
Yeah.
you are the cat is in serious trouble and you look like the world's biggest ding.
Yep.
Whereas, dogs have, they're like second almost to like cows. Like cows aspirate and they're like, yo, what's your point?
But dogs also like their larynx is just like, here comes the fluid, and the larynx is like, Give it to me.
Yeah, I agree. There's some nuances to cat anatomy and physiology, like why are they so hyper prone to laryngospasm over like, and let's not forget laryngeal edema, and then my personal favorite, where they do that weird mucosal blistering, like that comes up through their gums and their tongues and like occludes everything, and you're just like traking the cat.
Yeah.
They're also intolerant of trachs. Like, yeah, no, I don't
We
know.
also have way more asthma than we recognize too.
Yeah,
There's
I'm not
way
sure
more
that
feline
any
asthma than
clever
we.
answers
Oh
here. I mean,
yeah.
I know the lung ratio in cats and dogs is a little bit different, like the actual anatomy of the lung and its ratio to like body surface area or body weight, whichever way you want to correlate it, is different to a dog. But for whatever, and cats are just, they are designed to become inflammatory, right? Like everything makes a cat inflammatory, right? Like you just look at you put the catheter in the wrong way and they're like, I think I'm going to die of sepsis, like they're just hyper, pro-inflammatory little guys. And I'm not sure I have a clever answer, but my approach in terms of like cat ventilation, honestly, it's not going to be terribly different, similar parameters. And, I don't paralyze as much as I used to. When I trained as a resident, we paralyzed a lot of cases. And that was largely related to the fact that Cornell churns out a lot of the paralytic papers. But, and of course, in human medicine, they basically, everything gets rocuronium right at induction, right?
Yep.
It's
Yep.
like the default basis of care is that everything is like it's like you have an ingrown toenail and they're like, get the rocuronium, and I'm like, oh my god, um, calm down. The only reason I don't paralyze, I think, as much as I used to, is because the access to the paralytics is become significantly more restricted than when I was a resident, right? Like you cannot get atracurium anymore. Like
Yep.
cisatracurium is basically off the market here, and everything else has become now like vecuronium. Like a box of vecuronium is like exorbitant, so it's become cost prohibitive to do that. But I don't really remember, like it's not ringing a bell that I like disproportionately paralyze cats to control ventilation versus dogs. I don't know. I don't think I have a cat specific strategy. Beanie?
Yeah.
I to be honest with you, cats again, they're really, really rarely ventilated. They rarely require ventilation. Uh,
Mhm.
the ones where I tend to try to get more control is like diaphragmatic hernias.
Yeah.
Those are the ones where I tend to, if they don't, if I can't overcome their ventilatory drive, I just paralyze them.
Yeah.
But we use rocuronium at the moment, and it works pretty well. It's cheap enough, to be
Yeah.
honest. The adrocurium, like, it seems like once you pierce the bottle once or twice, like it stops working somehow. Like I don't
It's
know.
wildly unpredictable,
It
right?
is.
Like
It
you're
is.
topping up either every 20 minutes or every 4. And you're like, I don't understand what's happening.
Yeah, it's crazy. It's crazy. Rocuronium, I think it's way more
Bailey,
reliable.
do you have this like cat? I know you have a lot of cat theories out there,
Yeah.
but do you have a cat ventilation strategy you'd like to eliminate us with?
No, I don't. I will say I've been really like it is a when I have to ventilate a cat, it is a big source of frustration because they don't take to ventilation well. Their pressures just like completely tank. It can be really hard to get them to stop breathing. You end up having to drive their CO2 so fucking low that like you're just absolutely hammering the lungs, hammering the cardiovascular system, hammering like venous return. It's just like and at the end of the day, I just sit there and I wonder, like, okay, yes, this is like what the textbook says would be the smart thing to do and would like approach this the best, but like this patient in front of me is like screaming that this is not a good idea, but like
I hear
it
you.
makes no sense because like by every standard, if I didn't do this, this cat should be like dead as a stone, and like how do you reconcile those two things? Like I'll never forget. I'm sure I had a case as a resident where it's a uremic acidosis cat because it has a ureteral obstruction. Its creatinine is like fucking infinite. Its potassium is also infinite, and I can control CO2 to try and bring down that potassium a little bit while we start the bicarb and calcium gluconate and all that other stuff. And like somehow CO2's 30, 35, and the cat and PA CO2 to match, and the cat is still ventilating. Like, it's still fucking ventilating. And
I
it's
don't know.
like,
I'm not sure any of us understand cats. My biggest thing with cats is like you'll have like an undetectable Doppler pressure and they'll be awake.
yeah,
And I'm like, most things with a blood pressure or systolic blood pressure of 30 or 40 would be unconscious anyway. Like that kind of hypotension anesthetizes you from lack of cerebral perfusion. Not a cat. A cat is
yeah,
leaving. A cat is leaving with a pressure of 30. And you're like, I don't understand. And you're just like, I don't understand what's happening. Like you're hypoxemic, you're hypercapnic, you're hypothermic, you're hypotensive, you're bradycardic, you're acidemic.
yep,
Oh, but you're awake and trying to live. Right.
yes.
And you're like, I don't
Yeah,
think we
it's like,
cracked the Pandora's box open for secret cat physiology completely, but
ooh, I do. Your comment on Doppler did make me want to say something. We had a case the other day, healthy dog for a spay. It was an employee pet. We were spaying the dog. MAP 40. Dog got, I don't remember the anesthetic plan, but it wasn't anything crazy. MAP was 40. I was like, get the Doppler. Doppler pressure, 120. I was like, well, I'm done farting around here. We're going to go ahead and put an art line in this dog. Systolic pressure, 120.
I had today exactly
I,
the same thing, but the reason oscillometric was being unreliable is because it was a Shar-Pei, and when you put a cuff around 92 wrinkles of skin, it's not going to read accurately. No,
this was
really,
a
I'm not
Dalmatian.
disparaging the Doppler as ever being accurate, but I
This
will
was
point
a
out even a
Dalmatian.
blind squirrel can find a nut occasionally.
I was like, had we put the Doppler on the entire time, we would not be farting around with the art line. We would just have moved on with our lives.
Okay,
Okay.
congrats on your statistical outlier. That's not going to change the way we
Yeah.
practice.
So Doppler for the win.
Also, maybe buy better equipment for your non-invasive blood pressure.
I have not had issues. This is the first. It was very weird. It was on multiple machines. I still do not understand with different cuffs. Different. Yeah, I don't. I was baffled. I was very
Listen,
baffled.
Bailey, sometimes there are days where even my art line, I'm like, that's not real,
Oh,
right?
I know.
Yeah.
That's the fucking. When that happens, I'm just like, well, I'm going home for the day.
Yeah, like sometimes where I look at the art line, I'm like, this is absolute bullshit. Like, what is
Yeah.
going on? And it'll be like a perfect placement, blah, 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 and it's still rinky dinky. But like I said, once in a while, a blind squirrel will find a nut, and maybe today was the day your Doppler actually read the pressure correctly, and I'm
Nope.
happy for you. I'm happy for you.
I was
We're very
so
happy for you, Ryan.
I was overjoyed. I knew you'd all appreciate it. I knew you'd love it.
Are you trying to build back like the rapport and the respect from the earlier Doppler desert island comment?
No,
Because
no. This is me shouting out all my colleagues who reached out to me. Christine, for
one of
one.
them, one of
Be like-
them.
be like, I was so glad you said Doppler.
Okay, well, all of you need to be re-examined by the regulatory board. It's fucking outrage.
Are they all from Davis?
Yes.
Yeah,
Yes.
of course. Of
Those are
course.
Ryan's resident mates who reached out and were like, it's okay, Bailey. Dopplers are cool.
Hey,
Oh,
we all have our own, idiosyncrasies, and ours is just Doppler, and that's who we are.
Yeah, no, the entire faculty at Florida was like, what the hell is Bailey on?
I'm sure.
Yeah, team
Too much
Italy
Jardiniera.
/ Florida was like, no.
I can't imagine the entire faculty team of Florida is listening to this because I feel like they're really they've got better things to do than to listen to us pontificate about our feelings on anesthesia.
How dare you? They listen all the time. They have to
I mean,
because they're all
they
my
do.
resident mates.
Yeah, I guess that's true. They are your resident mates.
They have
Aw.
to.
I was like, they're much smarter than me, so they can't be listening to what I have to say.
Actually, I'd be surprised, I think, of how many veterinary anesthesiologists listen to us. And I think a large part of it is because we say things that don't necessarily get said because we're less worried about the diplomacy and the politics of it. And I actually think that's what gives a little bit of credence and merit to our podcast because these things need to be discussed, but nobody actually wants to say it. Right?
Sure.
Like nobody actually wants to say that Doppler is trash.
But that's the greatest invention of all time.
right? But like, I think like I've got, the people who I know who tune in, who are not just here for the hilarity and the hot dogs. They're saying, like, I'm so glad that you said that about fluids, or I'm so glad that you guys talked about the Dexmed, because that's what I think, but I never say it. Right. And I always feel like if I try to bring it up, like I just get bullied back down into like status quo. And I'm like, well, nothing improves and nothing changes if we don't have like the spectrum of opinion, right? Because that's what pushes us to actually like think and be better. So yeah, I mean, you'd be surprised how many veterinary anesthesiologists listen because they just want to have one other person just say the thing that they've never said, and I'm happy, we're happy to be those people for you guys.
The only reason I agreed to do this is so I could have a platform to just scream about Kat's sympathetic tone and why it's so dysregulated under anesthesia and why we need to do more about it. So,
Yeah. And apparently I've been just biding my time until the ventilation talk came up. Like,
I had so many other things to talk about, and now we like.
Yeah, but I spiraled right there because I was like, look, guys,
Yeah.
fucking ventilation irks me to no extent.
Holy cow. Well,
So Michelle's not buying any ventilators.
Wait, quickly, what's on the rest of your list? Just so like, I'm curious.
Let's see. I want to talk about like, what is your like, where are you sitting for permissive hypercapnia? How permissive are you, and when do you think that's appropriate and inappropriate? Are you actually doing anything about PPV, SPV in real time? Like when I know the human papers are all based on very low tidal volumes and very low peak inspiratory pressures, but in a real-time case, when you've got an A-line in and you can see like pulse pressure variation, systolic pressure variation, whatever number you want to choose, are you actually doing something about it? Or are you like, I'm hammering, there's certain cases where you got to hammer those lungs. You're at, high peak inspiratory pressure, high tidal volume. You're probably not going to do anything about it, but on those lower ones, do you actually assess that, knowing that it's not really what the papers say?
Maybe we need to have a ventilation part 2 discussion.
Sure. And then I wanted to talk, these are just topics I came up with off the top of my head, but I also want to talk about how do you approach discontinuing ventilation? And then I was going to do a whole thing on like, for those cases where we think ventilation is important, recent onset acidosis, sepsis kind of cases, uremic acid cases, they're not common, but we see them. The patients that you're going to kill by letting their CO2 climb up because the pH is so deranged that if you let it climb even further, you're going to set it to like, the death spiral, essentially. How do you approach intracranial pressure cases?
I think we should have a part 2. And
we should have a part 2.
Yeah, this list is excellent, and I think people would want to hear about, like, especially the intracranial pressure, because I also have feelings about that. But these are great questions, like how to discontinue ventilation, like permissive hypercapnia. We did that a bit.
I genuinely cannot believe I just thought it's just me over here fussing and like perseverating over little ventilator idiosyncrasies. I also want to talk about like when you have a patient who like clearly isn't taking to your like inspiratory time and flow rate. How do you make adjustments? Do you think it really matters, or do you think that patient has some other disease process? Anyway, I've got a lot of feelings about ventilation. I think about it a lot.
One of my mostest favorite to do is to come into a case and like the ventilation is just a hot mess, and I just go like this, boop, and I just turn it on.
My God.
And I'm like, enough of this bullshit. And then I start like a little like hand begging, and like I just sort of bring everything back to where it actually needs to be.
And then I also
ventilator, because I get so mad about bad ventilating, and I'm like, fuck this. And I just, like it's bucking. And I'm like, well, I don't know if you've noticed this, but every time it bucks against a breath, the airway pressures go up to about 42. So before we actually pop the lung, let's stop this insanity. And then, insanity. And then, let's just come back to like step 1. Let's walk before we can fly, and like think about what's happening. Is it depth? Is it pain? Is it position? Is it pulmonary physiology? Like what? Like blood gas? Like use your brain. This is my whole point about ventilation. You have to critically think now.
I also want to talk about handbagging. Is it all tracked up to date?
Yes. Okay.
Anyway, well, I'll leave it there for now.
Part 2. I think part 2 would be great.
Right, part 2, guys. All right. We came up to the hour. Thank you so much for listening. Remember, you can watch this on Apple Podcasts and YouTube.
And if you're a hot dog company, we are looking for a sponsor.
Yeah.
I will eat all
Sausages,
the hot dogs.
hot dogs and sausages, both welcome. We would also accept buns.
Nice. To be continued.